So it's Wednesday night. We keep thinking that it's Monday night, but it's Wednesday for Health Watch Oklahoma. And we have a great panel for you this evening. And I'll just start looking across this board here. I mean, I'm not sure how many people I've got muted, but I'm doing the unmute thing right now. And so there I go. And if you could have seen Patrick McGough, Dr. McGough, whatever he was doing back there, it was like a gymnast routine getting ready. It was like double back.
That's what happens when you find out 3 minutes before you're going to be on a show.
We gave you that much time?
Yeah, you did.
Okay. So we'll explain what and Maytubby. I mean, I have got double barrels of Oklahoma City County. So when I started getting messages earlier today going, what are they doing? And have anything to do with the invasion of Ukraine. And we're going to find out about that in just a minute. Dr. John Armitage is with us, Dr. Dwight Sublett, Dr. Dale Bratzler. One of the Fab Four is probably Sonny Climbs. If we know Dr. Bookman. So glad you're with us on a Wednesday night, which is still hard to say for the Fab Four plus two tonight. Don't include me in the Fab, but it's great to have the CEO of the Oklahoma City County Health Department, the COO of Oklahoma City County Health Department, Phil Maytubby. And so let me just start. Don't want to keep you guys on for long at all, which is basically this. I mean, some people were saying, hey, testing going on at City County and what's happening there. And so I called Patrick and Phil and said, why don't you just explain it? Because it's only taken me about 12 hours to have you guys involved in something that's not happening. So take it away.
Well, thank you, Scott, and thank you to everyone on the show for just giving us a few minutes. Happy to talk about that. So we're not certain yet. We'll make a determination about 5:30 in the morning whether we're open tomorrow for business or not. But as most people, we'll work tomorrow from our homes, even if we're not at the office. But I think there was a big miscommunication between some information about the weather and us not having a testing site, and then us reducing our testing because of the lack of demand. And we're kind of wasting a lot of personnel and workforce on testing at the City County Health Department when it's available pretty much everywhere and even in your own home. So that's kind of what's up with that. I would like to remind people to go to testokc.com one more time to give my shameless plug. And what we would like to do is encourage people, especially if they want to be tested at one of our clinics, that they literally call the number that's on there for our South location. They'll get an appointment where they can actually get a test at our South location. We were doing this after we had the big drive-through clinics of about 4,000 a week when Omicron was at its peak. Then we have begun to see that it's dwindled more and more and more. And as testing becomes readily available, almost no one is coming to the local health department. We're seeing between 1 to 5 people a day. So that's good in some ways, and we're thankful that we have so many partners helping doing the testing, and that's great. We're glad that testing, the need for it is somewhat decreasing, but we do want folks to know we're still providing that testing, and all they have to do is go to testokc.com. And we will also continue to provide upon request, like if there's a location where we need to send a strike team to just test a group of individuals in one safe type of setting, we can do that as well. But mostly it's in our clinics, and that's the way it'll be going forward. And I appreciate you guys just letting us be able to get on here and say that. I saw lots of things on social media today, like, does OCCHD have something they want to say? What's happening with the testing? And so thank you, Scott, and thank you to everybody on here for letting us talk about that, and we'll be happy to answer questions.
Well, can I start with the questions?
Sure.
Dr. Armitage didn't jump right in. When can we start testing for mosquitoes?
Phil, you need to unmute your phone and answer that question.
I will answer that question.
I'd rather spray for mosquitoes, but I know that's because at the rate of people aren't talking about COVID, I'm thinking skeeters are next.
Well, let's hope not. We had a pretty good down year this year for mosquito transmitted diseases here in Oklahoma. Some cool information, though, and Dr. Bratzler probably knows about this, but we do have the ability to test for flaviviruses, which are the viruses that are carried by mosquitoes and ticks in the sewage. So that's something that we're looking at doing to see if we have a bigger issue than we think we do.
It always comes back to sewage with Maytubby. Have you ever noticed that? I mean, first they're doing the checking the water for COVID. Now we're back with mosquitoes.
And you know what's so amazing about that, Scott, is they're leading the nation, because OU wants to talk about sewage a lot too, but there's a good reason for that. They're really leading the nation in some of the work that they're doing with sewage surveillance. So yeah, but Maytubby does take everything down to the sewer.
Hey, the OU team is great. They really are. I talk to them at least once or twice a week, and they're really doing some really good work out there that's getting recognized nationwide. So, every time I get a chance to put the plug in for that, I'm going to.
And Scott, I want to know, have you already done a big congratulations to Dr. Bratzler on his big promo?
Well, we were just messaging back and forth here, and I hadn't had a chance to get into that because, well, I didn't want to drag him into the sewer. I'm so sorry. That was such an easy setup.
Oh, I think we've lowered the standard of your show by Phil and I being on here. I think we're not doing you any favors.
I don't think, but now that Dr. McGough has brought it up, why don't you introduce Dr. Bratzler and tell us what everybody is talking about?
Yeah, I'll be happy to introduce Dr. Bratzler. Is that what you said? So the new interim dean at the College of Public Health. So thrilled to hear that good news. It's always wonderful to have a qualified person step into a role, and also very happy for the interim provost, Dr. Raskob, as well.
We just lost Dr. Bratzler. I mean, it just may have been too much.
It was too much.
It was too much. Do you guys know this Raskob fella?
Just a little bit.
Yeah, we know him a little.
Yeah. And I hear he hit the ground running in that new role.
Unlike most Canadians, which are stranded at the border right now. So I could not help that one. It was just like a truck on a bridge.
You're on fire today, Scott. You're
Absolutely.
on fire.
Where's that drum set?
I don't know. But
I was just Patrick on the story about the testing. Yeah. What would you think is do you have a target that would say that you're surveilling at a reasonable rate to keep open, or a reasonable rate to offload some of the burden from the hospitals? I know you've got historic highs that we're nowhere close to. You were doing land office business at one point, but
right.
Right.
Do you have I think too, that was our goal with Omicron when we were testing, was we were really trying to keep people out of the emergency rooms more than anything else, because we were hearing from the hospitals. I know Mercy had talked to me one day, and then I think Dr. Bratzler was on the same call, and we were kind of hearing that they were being overrun. And so we doubled down and we added a lot of folks, and we opened up our location. We were doing a lot of vaccinating at that new drive-through, and what we did was flipped it and made it a testing center, and then offered testing through a number of partners as well, as there's always been throughout the community. But really, we are down to the fact that it's not economical, it's a waste of staff time and everything else. So many people are offering testing, and I think now that everyone can get it into their home. And I was just talking to Phil a while ago that I would like to put it on testokc.com to explain to people how to order those tests to have them sent directly to their home, because I don't think we've had that on there, and that would be such a good thing for people to also know. And then the pharmacies, local physicians, everywhere that people have it available. So at this point, we don't know. I don't have a way of really knowing, unfortunately, and Phil doesn't. Dr. Bratzler may have a miracle way to know, but we have no knowledge of how many people are actually getting a test.
So I can go a little bit further with that. So I think what you're seeing now is we're kind of transitioning almost to that point where this is going to become part of our endemic testing, like we test for flu, like we test for other things that you can send off to, any of the reference labs. I think that's where we're heading, in that direction, where this will just be one of those standard protocols where somebody comes in and they're ill and they request a test, and then we'll send that out.
Do you see because of your expertise in the epidemiology and the, kind of the population implications, I was a little bit surprised that we went so deeply into home testing. I guess I haven't seen that previously with other, I haven't lived through many pandemics, but other diseases, that doesn't seem to be a kind of a go-to strategy. And we went all in and we did a lot of it. And obviously it's had some help, but let people know whether they should stay home and quarantine and do all that. But do you have an assessment of, what were we trying to accomplish, and did we do it with all the home testing, and will that be something we should lean into heavy in the future?
Well, I mean, in this circumstance, we just had it available, and it was specifically antigen testing, which is really good if you're sick. So, it was one of those good stopgap measures. If people couldn't get access to PCR testing, but they were interested, or they were exposed but didn't feel sick and they wanted to, try to do the home option. So, the bad side of that is that doesn't get reported. So, and I'm sure Dr. Bratzler can go into that here in a minute. But, what that means is, at some point, probably about 2 or 3 weeks ago, we were saying, look, we think our caseload may be 2 or 3 times what it is because people aren't reporting these tests in. I mean, they're just taking the test. If they come up positive, they're assuming they have COVID and they're staying home or not.
So Phil, I would agree with you. I mean, pretty much throughout the pandemic, we've assumed that testing hasn't been catching everybody. And even at the peak, there were asymptomatic or minimally symptomatic people that weren't getting tested via PCR. So we just made the assumption that what we've kind of told everybody in our health system was just assume everybody's infected. Just, that's the safest way to be, just make that assumption. I do know quite a few people who did do the rapid test at home, tested positive. Their work already had a policy that if you tested positive, you don't come to work. And so they just didn't see the need to get out, try to go stand in line somewhere, or go somewhere and get the PCR test done. Just didn't see a need for it. So I think there were a lot of people that tested, probably were positive, particularly during the most recent surge, and just simply never went and got a PCR test.
So from what you're saying, do you think that in some future variant surge or new pandemic, hopefully not, that home testing becomes an option at some sort of peak of a curve where we want to try and get people to stay home and there's high transmissibility? Obviously, Omicron was a lot more transmissible than Delta and the first variant. So, I mean, is there a kind of like a sweet spot where, we help ourselves and we don't, just have a lot of people testing at home and confuse ourselves as to the numbers? And
well, you want that one, Dr. Bratzler?
Well, I'll just start. I mean, John, it's one of those questions that we've been discussing with our team. What is the best metric to use in the pandemic? And when home testing became common with the large number of Omicron cases, we decided that hospitalizations was the number we were going to focus on most importantly, because that one, it's a pretty solid number. You don't fake being in the hospital. You don't not report being in the hospital. So we kind of moved to hospitalization as our principal metric we used. The other one we used at the Health Sciences Center was we looked carefully at the number of employees that we had that were either quarantined or isolated. And so those became our big numbers. And as those numbers have come down very rapidly, we're actually pretty comfortable that the big drop in the case numbers also is real.
So the purpose of the numbers that we see day in and day out, we really shouldn't be looking at absolute numbers, because there's really with the home testing, there's not really any way to have any clear idea the absolute numbers. To me, it seems that the numbers signify a trend, either up or down. Is that what we're looking at there, Dr. Bratzler?
Well, certainly they show us the trend. And, let's face it, during Omicron, there were a lot of people who were sick. I know Phil and Patrick saw a lot of people that came through to get tests done because people were seeking the test because they were getting sick fairly quickly. But as more and more home testing became available and fewer and fewer people were getting infected, it just became another option that people could use. And of course, in Oklahoma, we didn't make any attempt to capture. There was no voluntary reporting system.
Right.
So we don't know what the numbers were.
Gotcha.
Well, John, you asked something earlier about what was the goal with all of that. We had which we were proud that people would receive an ability to test at home because it did alleviate some other, problems that were being created. But at the same time, that was not organized from a federal level with us on a local level to know, so once you provide these people with these tests, it's up to them whether or not they want to volunteer and call us and tell us that they're infected so that then we could trace it and then we could help mitigate it. But I think it also was a form of helping people mitigate things themselves if they would take true public health education and follow the messaging. And if they knew that they were positive, then do that. I think that's something we could use in the future, like when we get to, God forbid, we're ever at pandemic level. But if we're at another pandemic, that's what we do from the beginning. Everyone tests at home. Here's the instructions. Here's what you do. You report this to your boss. You report that to school. You don't go anywhere. All those kinds of things. And then we could quarantine in a much different, more what seems to be popular, the individual and the freedom to choose way rather than someone dictating to people. And I think it could be helpful in the future, rolling it out at the end or hopefully toward the end of a pandemic and then giving everyone the ability to test themselves and then tell no one about it was not extremely wise, but it did help in some ways.
Yeah, I guess that was my thank you for that answer. I guess there seems like there's a gem of true value at mitigating some of the worst effects of a spike when it's at its worst, or but it seems like we might risk not capturing the best learnings from this. And then if we think home testing could help at the beginning of the next wave, we should be developing the training videos. What I'm learning is nobody reads anything, and you better turn it into a TikTok video, or you
got 30 seconds or less. Yeah.
Right. So, but we could be developing those tools now if we were being really kind of aggressive about capturing the upside.
Well, and the other thing, to take us back down into the sewer for a moment, that was what was so nice about the sewage surveillance and all of that. Because even if people are not reporting, in the future, what we do need to do is look at that. Early on, they were thinking as much as 14 days out, and they realized to be really certain it was more like 7 to 10, I think. And I'm getting into Dr. Bratzler's area, but I do know that something where there's no effort on the part of humans is the best way to go. And so if we're simply sampling the sewage and then we know where the virus is and we know this whole area has it, and we can alert people, and here's the precautions. And again, maybe like Dr. Bratzler, I think it was saying earlier, is we simply say, assume everybody in zip code 711 whatever has it, because that's where the sewage shed is showing that all of it's located. I mean, there's just a lot of stuff you could do with that.
You make me worried. We're going to have people worried about the surveillance, and they're going to go off grid.
No. Hey, I did want to bring up a relevant point that Dr. Bratzler brought up, and it's on the metrics, the transmission metrics. So, up from the start of COVID, we were using case-based transmission dynamics. That has got to change, because that is not the true impact that we see on our population. So as these variants, decrease in their ability to make people sick or put them in the hospital, that loses its relevance. Now we have to look at burden. So I think Dr. Bratzler was right on there. The truest, best measure that we have are hospitalizations for our population. So I know Patrick and I talked to CDC today, and we can't really share everything we talked about, but that was one of the points of our discussion, was that transmission table has to be redone. There has to be a different way to measure. because we are going to at some point get to an endemic status on COVID.
It's interesting you mentioned hospitalizations because that's where we started. I mean, way back in the beginning, there was a burden on hospitals, and that was March of 2020. It seems like, and obviously ICU beds and things like that were thrown in, but seems like that's the heart and soul of capacity and our ability to respond humanely to ill people.
It is. You're correct. It's finally how we always circle back to what we started with.
with only 2 years of politics thrown in.
I haven't quite got ready to do my slide, but I'm working on it because I'm just waiting for Dr. Armitage. Whenever you said CDC, throw up my slide. I'm not going to do it though. Well, is there anything? So to make sure that everybody understands, the testing could resume pretty soon in terms of the clinical setting, right? But basically, there's no demand for the giant drive-throughs, and that's just dried up quickly, right? So you can't have more people staffing these facilities than are coming through them.
Yeah, that's very, very true. And we want to leave those the availability there for everybody, but I think it's drying up all over the place. And there have been some great partners and Emmy Labs. Lots of folks have offered all kinds of, but I think it's decreasing rapidly everywhere. And we have a small workforce. I don't think most people know, but City County Health Department only has around 270 employees for all of Oklahoma City and all of Oklahoma County. And so we can't really leave a team of nurses standing in an empty drive-through. And so if there's no demand, we have lots of other public health activities they need to be involved in. So
I just want to, you guys may be dialing off here, and I just want to thank you again. I know we've said it before on this show, but to have the capabilities of the surveillance and the information is great. But when you're stepping up with your staff to help the hospitals and deflect cases, testing inquiries into ERs during the tip of the spike, it's almost like having an ancillary, medical SWAT team. So, thank you for being that flexible. I don't think, when you want, when people talk about government, I think you're showing a great example of flexible problem solving, which thank you for that.
Well, thank you very much for saying so. And I think that's what folks need to know, the difference between a national and a state and a local health department. Local health departments are, embedded within that community, and the needs of the folks in Oklahoma City and Oklahoma County, the demographics and what we deal with is very different than rural Oklahoma, which is where I grew up, Hayworth, a town of 300 people. And I know the needs when I worked in public health in Southeast Oklahoma are very different than the needs in Oklahoma City and Oklahoma County. And it's all public health, but the communities, the populations, the demographic, it's just all so very different. And we have to be flexible and autonomous. And if we fail to do that, we really lose relevance. And I appreciate you making those comments. And it's been our honor to work along with the hospital systems here. I think Oklahoma City has some of the greatest hospital systems in the country. And I don't think that all of our residents realize what we have. And it really, really has been a pleasure. And the CEOs of these hospitals have done a phenomenal job as well. Great. And I would not, many people talk about how horrible my job is. I would not have wanted to be a CEO of a hospital during all of this either. And I just think the challenges have been phenomenal for doctors and nurses. And so thank you, gentlemen, for the work that you've done throughout the pandemic as well. And unless my boss, Scott Mitchell, has anything else he wants me to say, I guess Bill and I are going to say farewell.
Well, one quick thing, because since we're just saying such nice things about you, I've already done the thing about the Canadians, but I think there's 2 more days left in the reign of terror of Dr. Raskob, right? And is he done as of effective March the 1st, somewhere in there?
I think it's sometime in March.
Sometime in March. Okay, so to be clear, Dr. Gary Raskob is about to leave his term as the chair of Oklahoma City County Board of Health, and which enables he would throw a shoe at me if I didn't do this right. But the interim dean of the Hudson College of Public Health at the University of Oklahoma is Dr. Dale Bratzler, because it was always that's the Hudson College. It's Hudson College. I've got it, Dr. Raskob. And so, but we are going to put an American in that position now. And so I'm sorry. It's the whole Canadian thing always trips me up. But in all seriousness, and I know my phone will ring fairly soon. Dr. Gary Raskob has led that board and that agency, and under his guidance, Dr. Patrick McGough is now the CEO. Phil Maytubby now the COO. We can keep him working for a few more years. I know the lake beckons, but been a couple of years going on. It's have some background, but this is what we have here because of the Dr. Gary Raskobs, the Dr. Dale Bratzlers, Phil Maytubby, who before long will be warning us to wear DEET, wear sunscreen, because nobody wants to be like this guy right here, right? Just hanging out. No sunscreen, no mosquito protection. Nobody. Now that is not. Phil did not take this down at his lake house. Okay, this is. So
it did kind of look like Canada.
It sort of did look like Canada in the background, didn't it?
Oh gosh.
They may have invaded there.
Well, Dr. McGough, Phil Maytubby, thank you both very much for all you do, and we want to make sure that people knew that the end had not happened to the OCCHD. It only takes a couple of media reports, and there you go. So thanks for clearing all this up. And by the way, to everybody at OCCHD, man, what great people, what patriots to do what they've done the last 2 years.
Thank you.
Thank you very much.
Thank you, Scott, for your service on our board. I don't know if you've announced to everybody, but Scott's term ended. And Phil and I have probably worked more with Scott than practically any other board member, perhaps Dr. Raskob. But Scott has been a world of help to us and has served for 2 terms, I guess. And we greatly appreciate that. And we're looking forward to continuing working with him. And we will be working with Dr. Bratzler, whether he ends up on our board or not. But we appreciate those plugs you're putting in there too, Scott. So thank you very much. And thank you all for letting us drop on the show.
Thanks, Dr. McGough. Thanks, Phil.
Thank you.
All right. So there you have it. There's I just took Dr. Bratzler out. Didn't mean to do that. So I guess you've heard. So it may be a noise on my end, Dr. Bratzler, yours. So if you'll just, I'll leave you unmuted, you mute whenever you want. We've got some sort of background sound. Gentlemen, thoughts about what you just heard from the living with COVID future?
Well, I like the ring of optimism there. I think it almost felt like a little bit of tangible relief that we're coming out of the third spike and getting down to some thinking about what endemic means and what surveillance means in the endemic world. And I'd hate to put my head above the trench for the third time and get it shot off, but it might be a morning in America.
I would agree with that too. Now, the last time we were on, we talked about a different variant of Omicron. I haven't heard much about that. Is there anything new on that we need to know about, or is there any other variants on the horizon that may pop up? Any thoughts there?
Yeah, so right now the Omicron subvariant is a subvariant of Omicron. It's BA.2, BA.2. It has been identified. One case has been identified in Oklahoma. It was actually an Oklahoma resident that was tested in another state, but had gotten infected in Oklahoma. And it's been found in about 22 states. But I highlighted earlier today in a presentation that when we hit the peak of Omicron, the top 10 states were consistently having somewhere around 500 new cases per 100,000 population a day. Today's data, the top state in the country had 80 cases per 100,000 population per day. So despite the fact that this subvariant's been found in 20 or more states, it's not taking over so far, which is some good news.
Is there some thought that the subvariant is a little bit hard to tease out from the regulars. So we're probably underreporting it, just the difficulty to differentiate it. But it sounds like even with that, we're not looking at a tsunami anyway.
Yeah, so I don't know all the details of testing. I have heard some of the same things, that it can be a bit more difficult to actually sequence. But like I say, we've made the assumption, our team pretty much has made the assumption that it was in Oklahoma. It was in Texas. If it's in Texas, it's in Oklahoma. And one case now has been explicitly identified in our case. I'm sure there are many more. But the good news is, it just hasn't taken over.
And even if it did, it wasn't thought to be much different clinically. So it might have a different label on it, but it was the same sweater.
Basically.
At least from the virulent standpoint, it was very similar. Most of the studies suggested, though, that it was more contagious, even 30% more contagious than Omicron, the original Omicron. So that's the only big difference I've seen, but it did not seem to increase hospitalizations or death.
Thanks.
All right. There was one thing that Dr. Bratzler had a little background on this. 2 peaks ago, Dr. Armitage started us up, but already going to start grinning about this one. We began the program a year and a half ago, which was called COVID Watched, if you recall that.
Mm-hmm.
And then Dr. Chansome, Dr. Armitage, Dr. Subas started saying, this is going to go away really soon. And so we changed the name.
We had to figure it out. No, we really,
we all were thinking that one.
Yeah,
so.
there you go.
Unlike me, we did a 60 straight days. When it's happened, we did 60 straight days from Tower, thinking 60 days would get it handled. But nonetheless, the doctors had said, and we had said this publicly on the program, we're going to start shifting towards other things that were being neglected. People going for their visits, people delaying operations, all these sorts of things. But one of the things that was unanimous across the board is we needed to spend more time discussing mental illness and mental health issues. And over the last couple of months, not only this program, but our Monday night program, we began to talk about what was happening at the county jail, which is about to be even more in the news in terms of discussions about a new jail. And there's been discussions about improvements of the old one, but pretty much you could say this objectively. I think most people know that's not going to fit the bill for the future. That's a firm grasp of the obvious. So now the discussion started about what a new facility looks like. How big is it? People saying, no, you build it for X, you'll fill it to X. All these discussions. You've seen the protest. You've seen the public passion about this. But recently, I was started doing some interviews with folks it was interesting that they were involved in these conversations, like the Greater Oklahoma City Chamber of Commerce. And so today, this is really brief, about 7 minutes. I had a chance to interview the president and CEO of the chamber, Roy Williams, and they're talking now about some of the aspects of how you would fund such a facility. And is it good for the population? Is it necessary? You've got the ARPA funds out there. The state uses this facility for DOC. And so I had a chance to ask him a few questions. And then after this, we'll open it up for the docs. They have some more things to talk about. But this was Roy Williams this afternoon. Here's just a brief amount of what we talked about. Why is the Oklahoma City Chamber of Commerce, the Greater Oklahoma City Chamber of Commerce, involved in discussions for a new jail? How does this Chamber of Commerce wind up in the middle of a discussion about incarceration and mental health, treatment for mental health? How is that?
A number of reasons, but if you go back about 6 years or so ago, we were approached by the chairman of the county commissioners and really expressed their concern about the need for facilities, about the problems they were having with the Department of Justice, about a concern that if something wasn't done, then perhaps the DOJ might actually come in and take over the jail, which is not something you want. But we continually found that when we polled the public, they were not interested in building a new jail. And so the commissioners were just, kind of at loggerheads about, well, what are we going to do? And so this was a discussion we had at one of our executive committee meetings, and Clay Bennett basically said, we've been having this problem for a very long time, and the problem isn't going to solve itself. So if the chamber would agree to support me, I'll put together a task force and kind of see what do we need to do here. What's going on? So that led to us hiring the Vera Institute of Justice out of Washington or out of New York to come in and tell us what's going on in our jail. Because at that particular time, there was no knowledge of really who was in the jail, why were they in the jail, how long were they in the jail, et cetera. And at that time, we had about 2,700 people on a daily basis in the county jail. And the county jail was built to hold 1,250 people, each in one cell. So tremendous overcrowding, et cetera. So what we learned was, after a lot of data got compiled, was that there were probably a lot of people in that jail we really didn't want in that jail. They didn't need to be incarcerated. And it was impacting their lives. It was impacting their families' lives. They were losing, their home, their car, their child, et cetera. And so that's when we eventually put together the Criminal Justice Advisory Council to really bring the players of the criminal justice system together. And as a group, talk about the issues, talk about how we can reduce population, talk about, treating and diversion, which we didn't have any of those in years past. So it really wasn't something that is normally in the wheelhouse of a chamber of commerce, but we felt that if we didn't roll up our sleeves and get involved in this, and the business community didn't get engaged, the Department of Justice eventually would. And that was sort of the last thing we wanted to see happen.
With all of your work at the Greater Oklahoma City Chamber and all the folks that have worked so hard on this, do you think now is the time for the discussion of building a new jail to occur?
Yes, I do. And there's reasons for that. If you look at the daily population count in the county jail today, it's south of 1,700. So this work we've done over the last 5-6 years has really reduced jail population by over 1,000 on a daily basis. And what we've learned is it's kind of flatlined, that seems to be the number that we can consistently see and consistently contain to that size. So we've seen stability now in the population. And before, there was talk about projecting population in the jail, and we were going to have to build a jail that was over capacity of 3,000 people. Now we know we don't need to probably be even half that size, but close to it. But we also did some polling recently of the voters of the county. And what we found was they're there. They are ready to take this problem on. They now believe, because there's been so much coverage of this, that we have to fix this. And we can't fix it by simply building a bigger jail. We have to continue to work on all of these different programs that are in our criminal justice system. And so the time is now. The voters are ready to build a new jail, but also incorporate all of these things we need to do to lessen the population of the jail, and also treat the people who either have mental illnesses or who have substance abuse problems, rather than just locking them up. And so we think this is a really good time that the voters are there.
So we had Representative Kennedy on the other day, Chairman Kennedy. We're talking about the state's looking at funds because DOC uses that facility. People are trying to put together a financing package, and it looks to me that's presumed you'll have to be a jail bond election. So your membership and the leadership there, we need to do something about the new jail. Do you think they're also in agreement to really push this bond issue if it goes before the voters?
Yes, we have historically run all city, county, school district bond issues, the MAPS initiatives and stuff. So, we have experience, we have knowledge about how to do it, and our leadership is there. Yes, they are ready to take this on and to lead this effort to get a new facility constructed.
Finally, mental illness, mental health. Most everybody we've talked to on this is that building down there is not a good place to be treating. You really can't do treatment down there. For the future of this community, and as the chamber has led the way on this, for folks who look at this issue and they go, what's mental health treatment got to do with incarceration? Walk us through that, if you would, Roy.
Yeah, when we first brought in the Vera Institute, and they basically did a snapshot of who was in the jail at that time, over 400 of the people in there had mental illness problems and were getting zero treatment. Over 200 had substance abuse problems and were getting zero treatment. So, I mean, what that tells you is they sit in there until they serve their time, and then they're let out, and they still have the problem that caused them to come in the first place. So they're probably going to be right back. So it made no sense to not divert and treat instead of incarcerate. And so, you know, we have seen that the public is there too. The public wants us to treat these people and turn them from liabilities into assets instead of them costing us money. Help us share in the cost and be productive citizens. You know, an interesting thing about all this too is, in light of the low unemployment rate we now have, it's difficult to find people to put to work. So there's also a part of this of training, upskilling these people as they do their time. And employers are now looking for them as a source of labor during this really tough shortage. So there's multiple benefits that can come out of treating people and getting them back on their feet and making them productive citizens instead of just incarcerating them at our expense.
Thoughts?
Yeah, I couldn't agree more. I think one of the things that we're quite familiar with, it's not unique to Oklahoma City, it certainly impacts our whole state, is the lack of treatment facilities for mental health professionals to actually provide that care. Desperately needed. And it's going to be a while, I think, before we have the resources to actually provide that care that's needed.
Well, one problem we have, we could get treatment in the facilities. It's the follow-up I see a lot of times outpatient once they're out of the facility. The long-term, that is a tough order, and sometimes do we have the personnel to do that? But I feel like that they are definitely on the right track, because mental health issues do impinge on this whole thing of incarceration. It's been said that the jails have become the present day mental health institutions we used to have. We don't have those anymore, and a lot of these people end up incarcerated. But I think long-term follow-up, that's a concern I have. One thing I see is that we can get things started, but they get out of the facility. Is there going to be places available, options for these people to follow up and keep on their meds or whatever treatment they're on? That's a concern.
Yeah, I would echo. I think anytime you're talking about more resources, better facilities, you know, you're probably on the right direction for a chronic problem that we've not been able to manage particularly well. It's wonderful to get, you know, a strong additional voice in the alliance of people who care about it. If the business community is really coming in with one relatively small but very important element of the overall spectrum of mental illness challenges we face, you know, that's win. That's a one more yard gained, I guess. But I guess I would love to see a group who can somehow frame the mental illness problems we have into some sort of overarching campaign that we can focus on. I think it's got so many different pieces, you know, whether it's got the jail piece, or it's got the substance abuse piece, or it's got the, domestic abuse. There's so many, you know, now the post-COVID, post-traumatic stress disorder that is probably going to be put in the diagnostic category soon. You know, there's just I think we struggle to have the right way to attack this, and we need people who could help us take this complexity, which seems so difficult to wrap your head around, and it looks like you're just using a fire, you know, a garden hose to fight a forest fire. How do we get a more consistent long-term commitment of the community to go along with the long-term consistent commitment we need with the patients for them to get better. You know, if you can't have an overarching long-term commitment from the backers who have to fund it, then you're very likely going to strand these people at some point in their journey.
Yeah. That's the point I was making. Is a lot of times you get the process started, but where do we go from here? That's where the rubber meets the road as far as long-term care, because these problems are complex, and we're now seeing them in pediatrics. We're seeing it in very young children with the adverse child events, and that we're dealing with the trauma in the homes, broken homes, et cetera, et cetera. So it is a very complex problem, but it definitely needs to be addressed. And I think this is a step in the right direction. I definitely feel that way.
And I guess I was thinking about the other day that, you know, the mental health challenges we have, that we don't have the right structures to say, well, what is the alienation of the internet and social media, and that's erupted in the last little while. So that's a kind of a variant on predisposing factors. But I was thinking about COVID and the pandemic. That's almost had the same traumatic effect on our society as Vietnam did. You know, you've got camp split, pro and con, and you've got, their own microcosm of information, and definitely people hurting, and lives lost. And there just seems to be this analogy that was an immense national trauma that we dealt with largely by living long enough to outlive it in terms of its immediate effects. We didn't really have a sort of an understanding of what it takes to heal from something like that. And that's part of the missing larger structure of how we deal with mental health. We can't deal with kind of community trauma, so we can't deal with individual trauma. They just don't seem to connect into an overall commitment or an understanding. But I would say there's something going on a national level that's feeding in. It's almost like a the only thing I can equate it to is like Vietnam and how traumatic that was for our country, losing that war, and the vets and how badly they were treated. But we don't really have a game plan from that experience to attack post-COVID, and it's a shame, and we need to do better.
Yeah, and the other thing I'll mention is we actually in this country we're starting to do a reasonable job at tackling the opioid crisis, which is now completely gone the other way with COVID. And when you look at the number of opioid deaths in the United States, most of them now are not because doctors were overprescribing. There's still some of that, but that's not most of it. It's recreational use, which just absolutely went up dramatically through the COVID epidemic. So another big national crisis that we're going to be facing.
And suicide is, we talk about that, by the way, every other week now on the My Mind Matters version of Health Watch Oklahoma. There is, by the way, Monday night, I'd like to get the doctor's take on this. Representative Logan Phillips, who is really the point man in Oklahoma on expanding broadband. And if you want to expand telehealth, you got to have broadband. And there's some legislation starting to filter out there. He's also an infantryman in his previous life. He's an educator. And have you guys seen any of the discussion about using psilocybin to treat PTSD?
Just a little bit, saying that there's some promising results, but that's all I've read. I would far from expert.
Something new. Okay, Dr. Armitage, you sent me a slide earlier, and I'm going to pop up here. And I know it's just merely a suggestion, but any chance that I can, you're always so mild-mannered on these issues when it comes to CDC. I mean, I saw you come through the camera when Patrick and Phil were talking to CDC. And so it was this little note that got my interest, maybe yours as well. And CDC refusing to publish data is collected on booster effectiveness for 33 million Americans, 18 to 49, over fears it might show the vaccines as ineffective. All right, so you saw this, and what is this all about?
Well, I think the title's inflammatory because that's how you sell media, but I think the underlying question it poses relates to a tranche of data that they released, and they left a gap on the validity of the data for 18 to 45-year-olds or something like that. And they said that, the data needed to be refined and polished, and they didn't want to release it with the other tranches of the data. But I think, and then there became a discussion back and forth in the kind of medical, statistical, public health community that's not the way you do that. You don't sit there and polish your data until it's at the point where you feel now you've massaged it enough that it can be released. You release it saying it needs further study. You release it and say, nothing can be determined as yet, and you let people see it. You don't sort of hold it back until you think it's ready for prime time if you're releasing the other data. Now, if none of the data is ready, great. Please don't release half-baked data. But if you're far enough along with the other tranches of the data, it's a little bit disingenuous to say that the 33 million, and there was some argument, they throw the number 33 million because, there's not enough data here for us to understand. Well, there's plenty of data there. It may be confusing. It may be hard to, pick out a definitive answer from that tranche. But I think that was the argument. And I just think, this is the CDC shooting itself in the toe from what I can gather. I mean, I'm not up close, and maybe Dr. Bratzler knows this data set better and will quickly disabuse me of my opinions, which will be great. But I just think transparency. People want transparency. They don't want gamesmanship, and this just smacks of it without better explanation. So,
well, I don't know all the details on this particular story, and I'm cautious because there is so much polarization about everything right now, COVID related. So I'm very cautious about looking at it. I spent a year working with the CDC as a senior policy advisor, and my experience was just the opposite. They are so scientific. They spend so much time drilling down into the details of everything that it seemed to me it was frustrating. Sometimes it took longer to get things out because they would vet it every possible way before they released information. That may not be the case with current leadership. It may not be the case with the emergence of the pandemic. But I think the big concern is it's not that the vaccines aren't effective. The question is, is it as important in a young person who otherwise is healthy? And I think that's one of the big questions that's arising here.
Well, and that's why people jump on this as lack of transparency, because that's the kind of the political hot potato. But and I think this is where science meets public relations and meets public communication. If that's the hot potato, then somehow pre-work the audience as to why you have to hold it back. Do some PR work for yourself, and don't leave yourself out there hanging saying it needs more analysis. Well, what is that analysis? Or anyway, I don't subscribe to there's a conspiracy at the CDC to hold back. I think you're probably right. They're overly diligent in an atmosphere where that's going to be totally misread to their disadvantage. And it's sad that they're not connecting those dots because their institution suffers for that. The same with the masks. I mean, there was data on the cloth mask versus the KN95, N95, and everybody sort of formed their own opinion, and a lot of it's to go away from cloth masking. But the CDC hasn't yet made a pronouncement on that, and I think they're missing a moment. They're missing a teaching moment where people are still even talking about masks. Give them another 3 weeks, and there will be very few pockets of people who are paying any attention to next surge. I better have a better mask. They will have missed the teaching moment if they're not careful, because it'll be a story that nobody wants to talk about when nobody's wearing masks anymore. And we're pretty close to that in Oklahoma now.
Mm-hmm. Well, the other thing is, it would be nice, and I know this is extremely hard to do. Because this situation is so dynamic, and it's been that way throughout. as to what we need to do and what we don't need to do. But having more concrete parameters to focus on, the public to focus on, as far as, okay, we're at a level now, we can shed the mask and fairly safely, or and in terms of the vaccine, more promotion there, that's in other words, more concrete information that just is more the public can pick up on better, if that makes sense, is what I'm saying. It's confusing to me sometimes. I'll just be honest with you. I don't know where we are, and maybe I need to be listening closer, but sometimes when you get so many different messages, and I don't know. I think that would help.
I think the CDC sidelines itself a little bit from relevance. If they're not going to make a mask pronouncement now, when everybody has to make their own personal choice based on what they surf on the internet, about which type of mask or whether even to wear a mask or not at this point, I went to, TGI Fridays and nobody was wearing a mask, so I decided not to. There's got to be almost like an express lane that the CDC develops for kind of rapid response with a giant asterisk next to it. This is a preliminary statement from the CDC, subject to revision within 3 weeks. But their cadence, they're killing themselves, to my way of thinking.
Well, you have to be careful. We had a situation this week in a fine hospital, won't name the name, in this town, where that they were having to get security because of some irrationality about treatment. People that on Facebook are better designed to do treatment than doctors and hospitals. Let me go around kind of a lightning round because getting close to the end of the hour. I want to go back to the guy, the man of the hour, who the interim dean there at the college, the Hudson College of Public Health at the University of Oklahoma. And so Dr. Bratzler taking over for Dean Raskob, who's moving across the town there. By the way, you got that good, he's takes up a lot of parking spaces there in the back of the building. I hope you've got him moved out of that. But in terms of for students that are in public health, and you've seen people leaving public health, nurses leaving, doctors leaving, hospitals working leaving. What's the challenge right now as you assume that mantle over there at the Hudson College?
Yeah, so we've actually already been having conversations about kind of two big priority areas. The first is building the public health workforce for the future. And I'm very cautious about not putting the word pandemic into those conversations, because I think COVID's going to go away. It won't go away, but it'll become endemic. And we have a host of other problems, some of which have been truly exacerbated by the pandemic that we've dealt with for the past 2 years. So we need nurses, but we also need nurses that understand concepts of public health. We're talking about how we can integrate public health training into medical training, how we can come up with certificate programs for people in the community that could work in rural facilities and others. So building the public health workforce is kind of at the top of the list of things that we've been talking about right now. And then the second thing, I've been very, very open about talking that we need to think about all the things we're going to be dealing with going forward. There were 3 different papers this past week that showed that cancer screenings dropped dramatically during the past 2 years for COVID. We're going to see a whole host of people present with more advanced malignancies and other things because of the lack of screening. And just thinking about all of the other problems. Oklahoma, cardiovascular disease is the leading cause of death. Cancer is number 2. We have chronic lung disease problems, kidney disease, liver disease. So that's also a big point of our conversations right now, is that we have to start thinking about those other really big public health issues in Oklahoma that are going to still be here after COVID is over.
Well, that's what we're trying to do every other week too. And what we've been trying to do for 6 months, actually, just to get to these other issues.
Can I put in a request for that public health workforce of the future, that if there's any way you can come up with a public or medical communicator certificate that would help us get the message out better? I mean, we've got to train PR staff at the hospitals and at public health institutions how to talk to the public in a way that bridges the gap. So I wasn't joking. I think it's a position, it's a skill set that needs to get the message out. The message is not getting effectively transmitted in a digital, increasingly non-written world.
I actually wrote that down, John. So I'll take that back.
It is, if I could, because I'm going to come to Dr. Armitage back because about blood here in just a second, but you've made this point several times, and in my career, which is north of 40 years now, I've never encountered a group of professionals that communicate worse than medical professionals. And there's not even a close second. And you know, I've not been shy about saying this. Doctors, hospitals, public health workers, they have other things going on. I mean, that's the big thing. You're trying to save lives. So you hear somebody say, you got to get some PR training. It's essential.
It's not in our curriculum. It's not.
Yeah.
We're on the one-on-one.
The exact opposite of effective communications for the public is rewarded in science, where you're very detailed. You anticipate every possible exception to show that you've got a sophistication around your concepts and your knowledge. And that is absolutely not the way that the public consumes its information. It needs to be, bullet points and not meticulous graphs, with many lines on them. But anyway, I would just say it's the opposite. You learn how not to communicate to the masses by going to medical school or into science.
Keeping it as simple as possible, straight up, as you say, less than 30-second type stuff. That's what the public picks up on these days. Yeah.
Okay, about 2 more minutes, so I want to hit a couple of things. Dr. Armitage, the state of the blood supply in Oklahoma, what do we need to be doing for OBI?
Well, the weather has just set us back. We're just getting out from the last one. We'd kind of dug out from the previous winter storm, and this one was, I think it was worse than a lot of people thought today. It's going to run into tomorrow significantly in terms of closures and maybe increased precipitation. So we're looking at a pretty big hurt. And now it'll be about rebound and recovery. As usual, Oklahoma's did a good job right before. We went in with what would be a pretty solid blood supply, but then you get busted back to private, and now you got to start working your way up the ladder again. So, that's where we are. We're going to need help. The need for blood doesn't worry about the temperature outside. I couldn't think of a lonelier place to be during a nasty snowstorm than sitting in a hospital room. And let's not give that family and those folks the worry about whether there's going to be a platelet or a red cell available for their loved one. Let's get them through this storm mentally, because we're just dealing with the physical. They got a lot more on them, and we can help. Come out, give blood. Share your health, share your joy at not being in a hospital right now, not dealing with chemotherapy. We do this all the time. We're asking again. It seems like a pandemic, we become beggars. The pandemic has forced us into a mode of asking for help over and over again. I hope we get out of this soon.
And Dr. Sublett, FDA's delayed the fast tracking the Pfizer COVID shots for kids under 5. A lot of parents are disappointed. Any conspiracy there? I've already heard some of them.
I don't know. I think it comes back that they want to be, absolutely certain that we're not going to get in a bind with this younger group. I get that. And I think some of the heat's off. The numbers are definitely trending downward in the kids as far as cases and that sort of. So they, I think, see that we do have the luxury of a little bit more time to make sure we get it right. We want the vaccine as soon as possible. We want to make sure it's right. They're still talking about in the spring. What does that mean? March, April, another month or so. If that means a difference of more certainty of what the product is that the younger ones are going to get is safe, it's probably worth it, particularly the fact that we are seeing a trend downward. If we were in, in the heat of it and it's not going away, then maybe we'd be talking a different story, but I'm not too worried about that. I don't know, Dr. Bradshaw, I don't know how your feelings are on that, but I feel like that's probably okay.
Well, I do too. And I think what may have happened is that in their dose finding studies, they may have chosen a dose too small for kids in that age group.
Yeah.
And so
So
just
they may
didn't give
tweak
them
things.
the impact that they thought it would.
All right.
And last, I want to bring Julie's question in here. Julie, could you, she's asked, share OBI info on your Facebook pages. But for people that want to know how to get a hold of OBI, Dr. Armitage, real quick.
OBI.org. You can look up blood drives or 1-877-340-8777. And one of our operators will hook you up with a chance to give blood, save lives, and be a hero.
All right. Thank you, Julie, for reminding us. Thanks to all the folks sending their questions in. We did get to a lot tonight. We had a lot of sort of breaking news with the Roy Williams appearance and also with OCCHD. And getting that issue kind of straightened out in terms of testing. So for Dr. Armitage, Dr. Sublett, and the interim director of the Hudson College of Public Health at the University of Oklahoma. See, Dr. Bradshaw, I've got it down. Thanks to Dr. Raskob. This is Scott Mitchell saying have a great evening. We'll see you in a couple of weeks. I'll see you Monday night on Newswatch Oklahoma. Have a good evening, everyone.
All right.